speaking today with Jason Abaluck from the Yale School of Management. Welcome, Jason. So, Jason, thank you very much for coming. I wanted to start by asking you, how did the healthcare come into all of this? Was it something that led you to economics or vice versa?
That's an interesting question. I guess I became interested in economics before I was interested in healthcare specifically. I think my interest in economics was just in what are the big social questions we can ask that affect human welfare, and I think that interest sort of led me to study healthcare more.
All right. So you mentioned sort of big issues in healthcare, and of course in both the United States and Canada, healthcare spending and healthcare change have been and are enormously significant and controversial issues. I mean, in the United States, I think about 18% of GDP is in healthcare spending, and it's slightly less than 12% in Canada, but it's big. And the tradition in Canada has been frequently to assume that more money is better. Throw money at the problem, and this will be the cure. Now, you're critical, at least in part of that, but in your paper you say that there's a fairly substantial body of evidence that suggests that more money spent on healthcare will bring benefits. So if we just looked at that side of the argument, what would the rationale be?
Yeah, I definitely don't feel like the right solution to healthcare is to say we're just spending too much and we need to spend less on healthcare and more on other sectors of the economy, because it's clear that health is something that really is valuable. I think the issue is, given that we are spending so much, we just need to ask the question, well, where can we spend that money that we're going to get a good return, and what are the features of the healthcare system that lead money to be spent in ways that don't yield a return?
Now, isn't it more or less inevitable that we're going to be increasing expenditures in healthcare, in part because we're living much longer, and in part because our demands on the system are much, much greater? For instance, in Canada, the Canada Health Act, which is a universal coverage, really focuses on acute care and doctors and hospitals, something that was appropriate for generations ago, where today chronic care is much more important. And the demands on the system are greater. People expect more from it. So aren't we just inevitably going to see rising in healthcare?
Right. I mean, I agree that there are clearly demographic features which will lead healthcare expenditures to rise over time. Now, when economists sort of look at the issues and try to say, well, what has been responsible for the rapid rise in healthcare expenditures in the past, there's, of course, always controversy about this whenever economists study anything, but it seems like a big part of that has just been due to the development of new technologies. And that sort of naturally raises the question of, okay, well, so are there policy changes we can make that will lead the right technologies to be developed? So one can imagine that there are different kinds of technologies, some of which are sort of extremely cost effective, and those technologies are developed, and it's clearly the world is better off having that technology even if we spend a little more. And that's something we would definitely want to have. And then there's other technologies where maybe initially the technology was useful. So you have something like a CT scan or something where it's probably good that this exists rather than not existing. It's helped a huge number of people. But there's also a lot of potential for abuse. And so the danger there is you want to design the system in such a way that you have incentives to develop technologies and then use them in the right way so that they are not abused. And that's the kind of thing that in the long run, maybe that can even slow the growth of medical costs and cause the overall value of the medical technologies that we have to be higher. If in part the growth of medical costs is driven by sort of the development of technologies that are being used on patients where they really shouldn't be used as much.
Mm-hmm. Now, you've said that there's a fair bit of waste in the system, but there really isn't very much consensus about what to do, how to get rid of it.
Yeah.
What did you mean by that?
Oh, I mean, I think that's absolutely right. And so the challenge there is that there are these studies that you alluded to earlier, which, and I know Joe Doyle was one of the earlier interviews, and he's done some of sort of the seminal work in this area that suggests that there are some types of healthcare spending. There's some places where we can look, emergency medicine, and I think also some of Joe's work on hospitals, where it looks like when you spend more, you do, in fact, get better outcomes. And so what that suggests is we can't just cut spending willy-nilly. We need to find those areas where we have really very clear evidence that you have money being spent, but you don't have resulting improvements in outcomes. And so the work that I talked about today is sort of a first step in that direction, trying to say, can we develop more precise measures of, for particular services, whether that service is passing a cost-benefit test or whether we want to try to change the way that that service is delivered so that we can do better in terms of costs and benefits, because there's some evidence that there's wasteful care being delivered that we'd like to incent doctors to avoid.
So you mentioned the work that you were doing and the talk that you gave today, which was terrific, by the way. So tell us a little bit about that. What was the research intending to show?
Yeah, so the very broad aim of the research is to try to develop a measure of the efficiency of doctors' medical testing behavior. And as is typical in this type of research, we're going to focus on one clinical environment where we think we can do the best job of that as sort of a proof of principle, and then hopefully these sorts of techniques can be applied a little bit more broadly. So we're looking at CT scans for pulmonary embolism, and our goal then is to develop this measure for each doctor to say, are they doing too many, too few, or the right number of CT scans for pulmonary embolisms given the patients that they have? And then to ask this question, given this measure that we've developed, what are the determinants of whether doctors do the right amount of medical testing? Do more experienced doctors do a better job? Do doctors at certain types of hospitals or in regions that spend more? How do we see what explains the variation in the efficiency of medical care?
And so what did you find?
So our main finding is, first, that there's an enormous amount of heterogeneity in doctor behavior, even when you try to control appropriately for differences in the patient mix. So it seems like even if all the doctors were treating the same patients, you'd see very varying rates of doctor behavior. With a couple more assumptions on top of that, we make assumptions about the cost of testing and about the benefits conditional on finding and treating a pulmonary embolism. It looks like the vast majority of doctors are doing too many tests. So we find, depending on the specification, between 70 and 90% of doctors seem to be erring on the side of testing too much.
So did that surprise you?
So in this instance, it didn't very much, because we specifically picked this clinical environment because it was a case where doctors anecdotally said that it was problematic, where so the American College of Radiology had already targeted this as sort of a procedure where they wanted to encourage reduction in use. And so part of our motivation here was just to provide a quantitative way of measuring whether or not they had diagnosed that correctly. And there are these welfare gains from reducing use.
So what does this imply then for, say, medical schools and medical education and hospital procedures? What would be the practical takeaway?
So it's an interesting question. So in fact, we look specifically at whether doctors who were trained at a higher ranked medical school were more efficient in their testing behavior. We did not find an effect there, although there's a number of caveats. Like, one is we didn't have a huge amount of statistical power. A second is we are just looking correlationally at the relationship between medical school and the efficiency of medical care. It's still possible that causally going to different medical schools, if we could get a causal estimate of that, would have some impact on the efficiency of your medical care. But so I guess in terms of where did we find things that might lead people to change their behavior? So one analysis we did was to ask whether doctors are correctly weighting observable characteristics when they decide which patients to test. And I think that analysis ultimately can better inform, could even be the basis of, say, like a computer program or something that would be linked to electronic medical records, where you don't want to completely take away the doctor discretion, but you would just say to them, look, given everything we observe about this patient, here is the computer program's recommendation. Now, given the additional, what you know as a doctor, you can make a more informed decision given that additional recommendation. So I think that's one way this research can inform things.
So I can see the implications of this, say, for medical education or at the institutional level for hospitals. But one of the people who attended your seminar today came up to me afterward. He's a distinguished professor of neurosurgery, and he liked your paper very much. But he asked me to ask you a question. He said, "Well, what would an individual emergency room doctor's takeaway from this be? Is there a takeaway for individuals at this level of research?"
Yeah, I mean, I think one takeaway from the work we've done so far is that they should just try to be very conscious of, like I think any individual emergency room doctor is not going to sit down and do a statistical analysis now before they decide which patient to test. But the fact that we find that there's this tendency to overtest should sort of buttress, I think, what the American College of Radiology and these other, and what has been anecdotally the emergency room doctors have been saying for a while, which is it does seem like there are too many tests for pulmonary embolism. So if they find themselves in a case where it's okay, this is a marginal patient, and I wasn't quite sure whether the American College of Radiology was right when they said this, this provides a little bit more evidence to help them feel a little more confident in that judgment that maybe on the margin they should be doing less testing. But
as I was reading your paper and then listening to you today, I was just wondering about hospital cultures. Now, your work looked at medical education and regionality. What about the culture of a hospital? And I'm just trying to imagine a university-owned hospital or a teaching or research-based hospital. Would that be an influence on individual surgeons?
Yeah, so we didn't find an effect of teaching hospitals per se, and we also didn't find an effect of whether the hospital was for-profit or not. But I think more generally, your point is very well taken, that there's very good evidence that the environment, especially in which you're sort of trained, has an impact on your behavior in these sorts of settings. So one of my friends from graduate school, so David Molitor, has a paper about when doctors are trained in one setting. Let's say they do their residency in a setting. I'm not sure if he looked specifically at testing, but whatever medical care he looked at, where they deliver a lot of medical care and then they move to another setting. Well, the place where they were trained matters a lot in the medical care that they subsequently deliver after they move. So it's clear that this kind of sort of culture and this idea of where you're trained when you learn to do these things matters. And now, I guess he actually had two findings, which is one, the place where you're trained matters, and also the place where you go to matters, what the other doctors tend to do in the place where you go to. So that definitely provides some evidence along these lines. One thing we have not looked at yet that we are planning to look at that's somewhat related to this is how does the doctor's own experience impact their testing behavior. So it might be that you're a physician, you just had a patient who had a pulmonary embolism. Now, that is not, in a statistical sense, all that informative about the likelihood that your next patient will have a pulmonary embolism. Like there are better sources one could look to try to make that inference, but nonetheless, what one might expect to find, and we haven't done this yet so we don't know, is that doctors will be very sensitive to their own past experience, and that if you've just seen a patient with a pulmonary embolism, then you're suddenly going to say, well, I better test any marginal patient because I don't want to miss that now that it's something that I've realized is a possibility. But that we don't have any evidence on that yet, so it'll be interesting to look at.
Certainly in both Canada and the United States, we're very much in the age now of looking at expenditure cuts and ways of making the system more efficient. And I wanted just to ask you a little bit about the Affordable Care Act in the United States, because it's so current and controversial too in the political sense. So on the one hand, we have the drive toward cost efficiencies or procedural efficiencies and cost reductions. And on the other hand, we have the social principles that guide large-scale public policy in healthcare. In looking at the Affordable Care Act or Obamacare, how are those two big sides of the issue going to be reconciled, do you think?
Yeah, so that's a very interesting question. So it's sort of from an economist standpoint, so we like to try to say, okay, by those social issues, like we want to try to give like a more precise definition for what something like that means. So one aspect of that is just sort of fairness or something like that. Like, is there equal access to healthcare that we think everyone should have access to? And I think from that perspective, the Affordable Care Act is probably going to be a clear improvement. Like, we see the evidence in Massachusetts when they had a similar health reform bill that it leads lots of people who were previously uninsured to get insurance. And we certainly expect to see the same thing in the United States.
Well, look, Jason, it's been a great pleasure. Thank you very, very much for coming.
All right, thank you.
I've been speaking with Jason Abaluck of the Yale School of Management.